Pancreatic cancer, it's notoriously aggressive, often diagnosed really late, at an advanced stage where surgery just isn't on the table initially. It's genuinely one of the toughest cancers to treat, a huge challenge for everyone involved, patients and doctors. So today we're diving deep into a really crucial study that aimed to move the needle on that. It's the JCOG1407 trial. It was published in the European Journal of Cancer. And this deep dive is all about exploring how this trial, this phase 2 randomized study, really rigorously compared two leading chemotherapy regimens for locally advanced pancreatic cancer, LAPC. Our mission here is to unpack what they found, figure out which treatment actually showed more promise. And not just about extending life, but also how manageable were the side effects and what does it all mean for future research, future options. Think of this as your shortcut to understanding some pretty complex medical research. So give me the key takeaways and maybe some surprising details too.
Yeah, and what's really fascinating, I think, is how this study plugs a pretty big gap in our knowledge. Because it was the first time these two powerful treatments were put, head to head in a randomized way, specifically for these LAPC patients.
Okay, so to really get why this study is such a big deal, maybe we should first break down LAPC itself. What are we actually talking about when we say locally advanced?
Right. So LAPC basically means the tumor hasn't spread to distant organs like the liver or lungs, but, and this is the key part, it's unresectable. Surgery isn't the first step, and that's often because the tumor's kind of tangled up with major blood vessels nearby, things like the celiac axis or the superior mesenteric artery. Removing it surgically right away would be, well, too risky or just technically not feasible.
And the challenge historically has been immense, right? The outlook wasn't great.
No, it really wasn't. Pancreatic cancer traditionally has had a very low 5-year overall survival rate. We're talking less than 5%. It's quite stark. And tragically, for maybe 80% of patients, by the time they get a diagnosis, the cancer is already unresectable. Either it's LAPC or it's already metastatic.
So what were doctors using before this study really clarified things? I remember gemcitabine monotherapy was a standard for a while.
It was, yeah. Gemcitabine alone, that was sort of the baseline standard. It gave about a 53 to 64% 1-year survival rate. But then these combination therapies came along, FOLFIRINOX and gemcitabine plus nab-paclitaxel, which people often just call GNP. These really showed big survival benefits, but initially that was proven in metastatic cancer, cancer that had already spread.
Oh, okay.
So because they work so well there, doctors started using them for LAPC too, which makes sense. But the critical thing was we didn't have a direct randomized comparison. Which one is actually better to start with in the LAPC setting? We didn't know for sure.
Right, and that really just underscores the need for clearer answers, better options. And I gather FOLFIRINOX even got a bit of a tweak, a strategic tune-up, you could say, to make it maybe a bit easier on patients for trials like this one.
That's exactly right. The original FOLFIRINOX, while it was effective, it was also pretty tough, lots of side effects. Patients often needed dose reductions or had to stop treatment sometimes. So researchers developed this modified version, M-FOLFIRINOX. Essentially, they lowered the dose of one drug, irinotecan, and they got rid of the quick 5-beat push of 5-fluorouracil. The whole idea was to improve tolerability, make it easier to handle, while hopefully keeping most of the effectiveness. That made it a much better candidate for this kind of head-to-head comparison.
Okay, so this is really where the study JCOG1407 comes into its own. It directly tackles that big question. FOLFIRINOX versus GNP. Which one is the better first choice for LAPC?
Precisely. It was designed as a phase 2 randomized selection trial. The main goal was to pick the preferable regimen, the winner if you like, to take forward into a bigger, maybe practice-changing phase 3 trial for LAPC. And importantly, it also let them compare how both these treatments stacked up against that older historical data for gemcitabine alone.
You really have to think about the patients facing this diagnosis, looking for the absolute best path forward. This study offered that direct comparison. Who actually took part in it?
So they enrolled 126 patients initially from 29 hospitals all across Japan. This was between July 2016 and August 2019. 125 ended up being eligible for the analysis. These were patients with untreated LAPC aged between 20 and 75. And they had to be relatively fit, what we call a good performance status.
Yeah.
Basically healthy enough to tolerate pretty intensive chemo. And interestingly, they also looked at specific genetic profiles, particularly something called the UGT1A1 genotype.
Okay, what's the significance of that?
Well, without getting too technical, checking for variants in this gene can help predict how a patient might handle certain drugs, particularly irinotecan, which is in mFOLFIRINOX. So it helps doctors anticipate and manage potential side effects better right from the start. It's a step towards personalized treatment.
Right, tailoring it a bit. And what did the actual treatment involve for these patients? Day to day or week to week?
Okay, so for the mFOLFIRINOX arm, patients got an intravenous mix. It had oxaliplatin, all-leucovorin, irinotecan, and 5-fluorouracil. They got this every 2 weeks. For the GNP arm, it was intravenous nab-paclitaxel plus gemcitabine. They got that on days 1, 8, and 15 of a cycle, and the whole cycle repeated every 4 weeks.
And what were the key things the researchers were measuring? How did they decide which one was better?
The main thing, the primary endpoint, was 1-year overall survival. So what percentage of patients were alive 1 year after starting treatment? But they also looked at lots of other important things, the secondary endpoints, like progression-free survival, PFS, which is how long patients lived before their cancer started growing again. They looked at the tumor response rate. Did the tumors actually shrink? They measured a tumor marker in the blood, CA19. And of course, they carefully tracked all the side effects, the adverse events.
Okay, the scene is set. Let's get to the results. This is what everyone wants to know. What did the study actually find? How did mFOLFIRINOX and GMP stack up?
Right. The results were, well, quite interesting, maybe even a bit surprising in some ways. So for that primary endpoint, the 1-year overall survival, GNP actually came out slightly ahead. 82.5% for GNP versus 77.4% for mFOLFIRINOX.
Okay, so GMP looked better at the 1-year mark.
It did. And importantly, both were way better than that historical number for gemcitabine, which was around 53%. So that's a huge win right there. But here's where it gets nuanced. When they looked further out, at the 2-year overall survival mark, mFOLFIRINOX actually showed a slightly better result. It was 46.2% for mFOLFIRINOX compared to 41.3% for GMP.
Interesting. So GNP better at 1 year and mFOLFIRINOX maybe slightly better at 2 years?
Kind of, yeah. And the median overall survival, that's the point where half the patients are still alive, was also a bit longer for mFOLFIRINOX, 23 months versus 21.3 months for GMP. So it's almost like GMP had a faster start, but maybe mFOLFIRINOX had slightly better endurance over the longer term, looking purely at survival.
That's fascinating. A real divergence there. Okay, so survival is obviously critical, but what about actually shrinking the tumor? Did one do better than the other there?
That's where things get really interesting and maybe tip the balance. First, progression-free survival. mFOLFIRINOX had a slight edge there too. Median PFS was 11.2 months versus 9.4 months for GNP. But the tumor response rates told a very different story. GNP achieved a significantly higher response rate. 42.1% of patients on GNP had their tumors shrink by a standard amount, compared to only 30.9% on mFOLFIRINOX.
Wow, that's quite a difference.
It is, and it gets even more dramatic when you look at that CA19-9 tumor marker we mentioned. GNP showed a remarkably higher CA19-9 response rate. 85% of patients on GNP had a significant drop in their CA19-9 levels, versus only 57.1% for mFOLFIRINOX. So GNP seemed much better at hitting the tumor hard and fast, causing shrinkage and reducing that marker.
That really is striking. So GNP wins on immediate tumor impact, even if the long-term survival curves were a bit mixed. And also saw something about conversion surgery, about 8% in both groups. That sounds like a really big deal for LAPC.
Oh, it's a huge deal. Absolutely. Conversion surgery means that the chemotherapy worked so well, it shrunk the tumor enough that surgeons could then go in and potentially remove it completely. Remember, these patients started with unresectable cancer. So for that 8% or so in each arm, the chemo opened the door to potentially curative surgery. That really highlights the power of getting a good response up front. And it brings up a tough question for the researchers and for doctors. How do you weigh those slightly different long-term survival numbers against much better immediate tumor shrinkage, better marker response, and maybe more chances for surgery?
Yeah, that's not a simple calculation at all. Okay, so we've got two effective treatments, both beating the old standard, but with these different profiles. One hits harder initially, the other might have slightly better long-term survival. But treatment isn't just about the numbers, is it? It's also about the experience, how you live through it. Let's talk about the side effects, the safety, and tolerability.
Right, and this was another area where they were quite different, and it ended up being really important for the final decision. mFOLFIRINOX tended to cause more severe gastrointestinal problems, what we call grade 3 or 4 toxicities. Things like significant diarrhea that affected about 17.7% of patients, and severe anorexia, loss of appetite. in about 16.1%. Overall rates of nausea and vomiting were also higher with mFOLFIRINOX, and unfortunately, these GI issues led to more patients having to stop the mFOLFIRINOX treatment early because of side effects.
Okay, so Empilferinox was tougher on the gut. What about GNP? Was it just easier overall, or did it have its own set of challenges?
It had its own challenges, just different ones. GNP was more associated with high-grade peripheral sensory neuropathy, that's nerve damage causing numbness, tingling, sometimes pain, usually in the hands and feet. That affected about 36.5% at a severe level. GNP also caused more issues with blood counts, what we call hematological toxicities, so significantly low white blood cell counts in about 44%, and really low neutrophil counts. Those are key infection-fighting cells in almost 80% of patients. That needs careful monitoring.
But amidst all these side effects, which sound pretty serious, there was some really crucial good news on the safety front, right?
Absolutely crucial, yes. There were no treatment-related deaths in either arm of the study, which is really important. It shows that while these are intensive treatments with real side effects within the controlled setting of a clinical trial, they could be managed safely, especially considering how serious pancreatic cancer itself is.
Okay, so putting it all together, the survival data, which was a bit mixed, the much better tumor response with GNP and these quite different side effect profiles, with GNP maybe being easier on the gut but tougher on nerves and blood counts, which one do they ultimately choose to move forward to the big phase 3 trial? And what was the main reason?
They chose GNP, despite mFOLFIRINOX having those slightly better median and 2-year survival numbers.
Right. Why GNP then?
It wasn't based on just one number. It was a comprehensive look at everything. GNP had the superior tumor response rate, the better disease control rate overall, that much more impressive CA19-9 response. And really importantly, the milder gastrointestinal side effects meant that more patients were actually able to complete the planned cycles of treatment, better treatment completion.
I see. So they could tolerate it better overall, even with the neuropathy risk.
It seems so. And that ability to shrink tumors more effectively with GNP, that also holds more promise for potentially getting more patients to that conversion surgery point down the line. It opens more doors.
Makes sense. So GNP goes forward to phase 3. But the study still concluded that both are major steps forward, right? What's the takeaway for doctors treating LAPC patients like today?
Exactly. The big conclusion is that both mFOLFIRINOX and GNP should now be considered standard first-line options for LAPC. They both blew that old gemcitabine data out of the water in terms of 1-year survival. So patients now have 2 highly effective, validated initial treatment choices, which is great news. The choice between them might depend on individual patient factors, side effect concerns, and maybe treatment goals.
It's definitely progress.
Yeah.
But like most studies, it probably didn't answer every question. Were there limitations? What's still left for future research?
Yeah, there are always limitations and new questions. One notable thing is that the study didn't routinely test for certain inherited gene mutations like BRCA1, BRCA2, PALB2, ATM. We know these mutations pop up in maybe 10–15% of pancreatic cancers. And crucially, they can predict sensitivity to platinum-based chemotherapy. Oxaliplatin, which is in mFOLFIRINOX, is a platinum drug.
Oh, okay. So if you have one of those mutations.
Exactly. If a patient has a BRCA mutation, for instance, mFOLFIRINOX might actually be a much better choice for them specifically. So that's a huge area for future research, integrating that kind of genetic testing up front to guide the choice between these regimens. The study also hinted, based on how the survival curves looked, that maybe there are other subgroups of patients who do particularly well or perhaps less well with mFOLFIRINOX. We need to understand that better.
That really connects to the bigger picture, doesn't it?
It absolutely does. This study gives us vital guidance for now, but it really hammers home the need for more personalized medicine in pancreatic cancer. The fact that this kind of genetic screening wasn't standard then, but is becoming more common now, highlights a really exciting, potentially game-changing direction for how we treat this disease moving forward.
It really does. And that leads perfectly into our final provocative thought for you, our listeners, to chew on. Consider this. What if genetic testing for biomarkers like BRCA becomes absolutely standard practice for every patient diagnosed with pancreatic cancer, right at the beginning? How might that fundamentally shift the conversation about choosing between mFOLFIRINOX, the platinum-based one, and GNP? What could that mean for individual patient outcomes? And not just survival, but also their quality of life during what is undoubtedly a very tough treatment journey. This deep dive really shows that complex balancing act in cancer care, pushing for efficacy while always considering the patient experience. What other questions do you have about how studies like this shape the way we fight cancer?